Well, traumatic attachment is the word we use for what happens to attachment in child abuse and domestic violence, where children live in an unsafe environment. And unfortunately, the danger comes from their attachment figures. So it sets up, the natural reaction of children who are not traumatized is to seek out the parent figure. Those of us who've lived through the early years of parenting know that you spend years with small children glued to your leg. You can't walk 2 steps across the kitchen without having this little person, right, holding on to you. John Bowlby believed that was a sort of evolutionary feature because children who stayed close to the parent survived to become the next generation.
Okay, Janina, welcome to the show.
Thank you. Thank you so much.
To get started, could you maybe tell us what is traumatic attachment and how might this show up in the therapy room?
Well, traumatic attachment is the word we use for what happens to attachment in child abuse and domestic violence, where children live in an unsafe environment. And unfortunately, the danger comes from their attachment figures. So it sets up, the natural reaction of children who are not traumatized is to seek out the parent figure. And those of us who've lived through the early years of parenting know that you spend years with small children glued to your leg. You can't walk 2 steps across the kitchen without having this little person, right, holding on to you. That's normal biological attachment drive, right? Keep your caregiver close. John Bowlby believed that was a sort of evolutionary feature because children who stayed close to the parent survived to become the next generation. Now, what happens when that person you have the impulse to cling to also happens to be the person who hurts you or frightens you? And what that sets up in children, and they've observed this at very early ages, at less than a year, what happens is the child still has that urge to seek closeness, but now it's coupled by the urge to fight or flee. So the child simultaneously feels I've got to get closer and I've got to get away. So it sets up a huge internal conflict in which the child doesn't feel safe being close to the parent, but also doesn't feel safe at a distance. Because as soon as they back away, they have the pull for closeness now starting up again. So it's very confusing for a 1-year-old. It gets even more confusing as it continues to play out through adulthood.
That strikes me as just such a tragedy, you know? It's sort of like if you were driving a car, you'd have one foot on the accelerator and the other on the brake. You're moving forward, but then every time you move forward, you have to jolt back. And this is you're talking there about John Bowlby, and he was he studied a lot of animal behavior as well, and it just reminded me when I do a lot of running here in the Irish countryside, and I'm always running along the roads, country roads, and there's always lambs like on the close to the fences. Whenever I run past, they always sprint to their mother and go to the secure attachment figure. Um, but something I was curious to ask Janina was about mental health professionals and attachment styles. Can you maybe share your thoughts on this? Like, do you think there is a predominant attachment patterns or pattern for mental health professionals? And I don't know if you'd be willing to share your own or not, but I was just curious to ask what's your own attachment pattern, if you'd be open to sharing that.
Well, certainly there's there are many therapists who have their own trauma histories, who might have in their personal lives, they might have a more disorganized attachment. In their therapy work, I'm sure they manage their attachment styles. There is an interesting piece of research, it goes back many years, where they looked at the attachment style of the therapist and the attachment style of the client. And they saw how they matched up. The best match was between a therapist who was more dismissing and a client who was more preoccupied, right? Like, which are again non-traumatic attachment styles, the dismissing, often called avoidant, and preoccupied, often called ambivalent for reasons that make no sense. so, so it was very interesting that it kept the preoccupied client and a preoccupied therapist from getting enmeshed because the therapist style was more dismissing. And I would say my own attachment style tends to be what's called earned secure attachment, meaning you didn't have secure attachment in childhood, but you acquired secure attachment through adult relationships, through therapy, through raising one's own children. Those are all opportunities to rework your attachment system. So I feel very lucky.
Well, we're going to explore that more later. But before we get into it, I'd love to ask you about how the work of Caroline Lyons Ruth impacted you as a clinician, because this seemed to be very important on your trajectory.
Um, well, and truthfully, her work, her work helped to make a bridge because she's a researcher who also is a clinician and who worked in a department of psychiatry. She made more of a bridge between the research and the clinical implications. And she was the first that I recall to make the connection between disorganized attachment or traumatic attachment and dissociation. So that's really what the part of her work that influenced me. Most of her work has been 30 years of studying the same group of what were originally 1 year olds. They're, of course, now in their 40s, I would guess.
Yeah, and the something that I find quite interesting about her work was the impact that frightening behavior of parents can have on children. Could you maybe speak to this a little bit?
Yes, and that finding was actually made a generation earlier by Mary Main, who was one of the first generation after Bowlby to study attachment. So what the researchers noticed at the beginning was they noticed secure attachment. They noticed what they called insecure ambivalent attachment, meaning children who were clingy and fussy. Um, Insecure avoidant, children who were kind of independent in their own little worlds. And then there was this fourth mysterious group of children who approached the attachment figure and then ran in the other direction. And they called those disorganized because they didn't understand what was going on. Then they noticed, because of course, part of attachment research is noticing what the child does in reaction to the mother. But the other is noticing, the other part of the research is watching the mother. And what they found when they watched the mother's behavior was that the mothers of these disorganized children engaged in behavior that was frightening to these 1-year-olds. Again, not the kinds of things that would frighten a 10-year-old, but things that would frighten a baby. Like baby runs toward mother, mother pulls away. Or baby is crying, mother has a shutdown, still face, if you're familiar with the still face study. What were some of the others? Mothers startled easily. And when they startled, that was frightening for the babies. Also, I'm trying to remember some of the other ones. The parent was intrusive. Their movements were awkward and sort of misattuned. They made loud, startling noises. They engaged in mocking the child. Imagine mocking a 1-year-old baby. It doesn't make any sense. So they saw this correlation between the 1-year-old's attachment style and these behaviors, which appeared to frighten the children.
Yeah. Wow. And so a memory comes to mind for me. I remember being about 7, I think, and I was on holiday with my mum, and I remember at one point she was visibly quite scared or frightened about something that had happened. And to me, this stuck in my memory for ages. Like this really upset me, So is the implication here that parents should, and I know we shouldn't, pretend to be something we're not or whatever, but is there a case to be made that parents should do their best to maintain or to be a source of strength during those maybe distressing moments so that the child looks to them and knows that there's just a safe anchor there as opposed to showing the fear? What do you think about that?
Well, I think we don't necessarily have to go to that extreme, but certainly what we don't want to do, if we're frightened, we don't want to show the fear in a way that frightens the child. So, if we're saying, oh my God, this terrible thing is going to happen, that will frighten the child. If we say, we've got to go inside right now because there's about to be a lightning storm. So come on, sweetie, let's go inside. That's, the fear is being expressed, but in a way that is reassuring to the child.
For sure, for sure. It sort of reminds me whenever I'm flying on an airplane and there's bad turbulence, the first thing I do is I always look to the air hostesses, and if I see a shred of panic on their face, I'm like, uh-oh.
Right. Yes, I do the same thing. Yes.
Um, I've heard you say that instead of asking, when a client comes to therapy, instead of asking where you abused as a child, you will often ask where your parents frightening as a child, and you find this to be quite a fruitful question. Can you maybe expand on this a little bit?
Yes, because many people will not answer the question, were you abused by either of your parents? Because it's a loyalty question for them, not a historical question. And or they may feel shame. There may be a variety of reasons for them to, or they may have minimized it. If I say, were either of your parents frightening, I get more of the details. And the details often include, oh, yes, you know, if I said something my father didn't like, I would see the back of his hand. Right. So you begin to get the actual data.
Yeah, no, that's a really good question to ask. Another thing I wanted to bring up in this interview was, I've heard you say that if you were made, president or ruler of the world, I'm getting the phrasing wrong. I apologize, but you would rename borderline personality disorder as disorganized attachment disorder or traumatic attachment disorder. Can you maybe tell us about your thinking behind this?
Well, first of all, I we have 30 years of research that demonstrates, study after study after study demonstrates that borderline personality disorder is associated with a history of childhood trauma. So already you see that the research says this is not a personality disorder. This is a set of symptoms caused by traumatic events. So all these 30 years, we've been treating borderline personality as a personality disorder, as the worst possible personality disorder that no one likes to have around them, when in fact, they're trauma survivors. And particularly, they show the impact of traumatic attachment.
And am I right in saying that we can actually predict borderline with, it correlates so strongly that you can predict whether a child at the age of 1 is likely to develop borderline at the age of 20, 21?
Well, that's what the research, like Carlin Lyons Ruth's research, the research of other attachment researchers, they show the same thing, that having disorganized attachment at age 1 is a statistical predictor of developing borderline personality disorder or being given that diagnosis in early adulthood.
And are the implications of that then, if we become aware of that, then we can intervene in such a way that we might be able to prevent the development of that later in life?
Well, that would be the hope. But as we know, we have social care systems which are really inadequate despite our best efforts. So you can't guarantee that if I take this child out of the home and place that child in a foster family, I can't guarantee that the foster family will be a better environment. And, and so, and then we have huge attachment issues that are caused by taking a child out of family. So it's very complicated. In the US, we simply don't have enough foster families. And so there's nowhere for the children to go.
It's terrible. Um, Another thing I was curious to ask you, Janina, was, is there anything that you believe about attachment or that you've experienced in your decades of clinical work that might surprise people or might go against the conventional wisdom or the conventional thinking in the area? Is there anything that, yeah, does anything come to mind when I ask that question? If nothing comes to mind, don't worry. I was just wanted to see if anything was there.
Well, other than saying borderline personality disorder doesn't exist, that's the most controversial. I suppose the other most controversial thing that I keep saying um, is that we pay much too much attention to the events that occurred, and we don't pay enough attention to the fact that abused children live in a traumatic environment, and that therefore they are traumatized every single day, not just on the day that they're beaten or abused in some way.
Yeah, yeah. We can never. It's so hard to overestimate the importance or underestimate the importance of the context around a person as opposed to what's happening internally as well. The two really go together. Um, I, and something else was around the window of tolerance. What is the window of tolerance, and why is this important whenever we're talking about attachment and attachment trauma?
Well, actually, I think it's important to think about when we're talking about anyone, but the the window of tolerance is a term originally used by Dan Siegel, and adopted and I would say publicized even more by Pat Ogden. And what it refers to is our bandwidth for tolerating emotion, stress, impulsivity, hurt, disappointment, you name it. If we have a wide window of tolerance, if it's flexible, then we can tolerate grief and other strong emotions. If it's very narrow, we have trouble tolerating any emotion. And it the problem is that in trauma, we rely on our nervous system's sort of highest and lowest settings. So in a traumatic environment, we the threat stimulates the sympathetic nervous system, which increases nervous system activation to prepare us to take action. So the sympathetic nervous system is all about taking action. That's why it's there. Now, little children obviously can't take action. Victims of domestic partner violence can't necessarily take action. Even soldiers in a war can't necessarily take action. But they still have that high arousal, fear, anger, hypervigilance setting. And our other setting for traumatic events is the parasympathetic low arousal, where the nervous system does the opposite. Instead of increasing activity, it reduces activity to the point at which we have the equivalent of sort of psychological hypothermia, where we have no energy, no connection to feelings. We're just existing.
And sorry to interrupt, Gina, but would it be that, like, how does a person or how would a person's nervous system decide whether to go into that highly aroused sympathetic state or that really low dorsal, like, would that be based on past experiences or would it be a calculation that happens under the surface? How would that happen?
Well, Stephen Porges says it is due to our ability for neuroception, for sensing danger. And the brain and body automatically adjusts to the type and severity of the danger. So if we're in danger, but there's room to flee or fight, we'll go into sympathetic activation. If there's no way out, if we're trapped, Then we go into parasympathetic dorsal vagal states because those allow us to submit and endure.
Okay. And then that can lead to things like dissociation and fragmentation.
Well, um, that in a way, dissociation is another category of responses. In the dorsal vagal state, the individual is not dissociated, they're just shut down. Imagine you're in a medically induced coma. That's probably the equivalent. Where, and that's a setting which is necessary often for women and children because they can't run, they can't fight, and they can't escape. So their bodies go into that dorsal vagal shutdown. And they can be seen and not heard. Children are very bad at being seen and not heard. It's not in their wheelhouse. So that parasympathetic dorsal vagal state helps them to be seen and not heard.
Oh, that makes sense. And if a child has a parent or parents that are abusive or frightened or frightening, how does that impact the window of tolerance?
So a baby's window of tolerance is dependent on the parents, right? So ideally, the baby cries, the parent feels a need to take care of the baby, experiments with what helps that baby feel less distressed. And then the baby goes, oh, and just relaxes in our arms. And we have these blissful moments of, everything's all right in the world. and, and there's a very deep sense of connection. Now, that doesn't happen with abusive or neglectful parents because they hear the baby cry and they either get angry or they want to run away. So when a parent intervenes and the baby feels distress and then is calmed by the parent, that's conditioning the nervous system to grow a window of tolerance. Now, they don't have it at 6 months yet, right? And they don't have it at 2, but over time you see the results in steadily increasing ability to tolerate their feelings without melting down.
So the extent to which the parent is attuned to the baby or the child is probably correlates with the size of the child's window of or the child's window of tolerance that they will develop.
Right, exactly.
And something else that I found interesting when I was researching for this conversation was children that, or even people in later life that find it really difficult to try hard and put a lot of effort into things and mobilize that sympathetic energy. This is linked with the window of tolerance and attachment in early life. Can you maybe tell us about this as well, Janina?
Well, just think if you have to survive as a child by not exerting energy because you're in that dorsal vagal state and there's no energy to exert. And that's how you survive. You kind of fly below the radar. Your parents aren't threatened by you. You kind of keep to yourself. And what that does is it's conditioning the nervous system. It's conditioning habits of not trying, because if you have no energy, you can't try. It isn't a decision. It comes from the fact we need energy to try.
And let's say that there's a therapist listening to this that has a client in that situation. Is there anything that they can do to help in these situations?
Well, they can teach the client about the window of tolerance and get the client interested in how their nervous system works. Because so often we diagnose those dorsal vagal clients as depressed. We give them antidepressant medication, and we talk to them about their depressing childhoods. That's not going to move the needle to change the parasympathetic dorsal vagal state. Right?
For sure. Sure. And you know, to me, this brings up another important point that attachment is pre-verbal. This is all learned before we have language. So it doesn't make any sense that we would use language to treat these issues, or maybe it does. I don't know, but it seems like we have to go a layer deeper. What are your thoughts on this?
Well, it's true. Talking about these things doesn't tend to change them, as many therapists have had the frustrating experience of seeing. So to change and also talking about attachment is very tricky, because if I say to the client, you have a traumatic attachment style, often clients are very defensive, very wounded, because it feels like we're talking about them. We're saying you have this deficiency. So, which is interesting, because if I say, wow, your nervous system is off the charts here, they don't take it personally. But if I talk about their attachment style, it can be very wounding, and then that makes for difficulty. They feel I've empathically failed them, that I'm critical and cold. So I don't, for that reason, I think talking about it doesn't work. But what I can do is I can validate the attachment challenges they have. I can provide a little psychoeducation, because psychoeducation is neutral, right? It's not about them, it's about the whole world of trauma survivors. What else can I do? And then I can help the client work with the attachment style as it comes up in the relationship. Because many, I mean, this goes back to the fact that we've diagnosed these clients borderline. And so everything they do, we say, that's personality disorder. As opposed to when they pull for closeness, when they're very preoccupied with whether we care about them, whether we're warm enough, whether we're going to abandon them. When that happens, the tendency of many therapists is to try to reassure the client. The difficulty is, it's hard to reassure a traumatized person, because traumatized people have been lied to. They don't believe reassurances. They've been told, oh, you're safe with me, right? Just relax. Nothing will happen. I mean, they've been told so many lies. And so they don't believe reassurance. So that generally doesn't work. And sooner or later, we're going to say or do something that hurts the feelings of this side of the client that wants to be very close to us. and wants us to love the client. And then we're going to get the anger, right? You miserable excuse for a therapist. You're a miserable excuse for a human being. You don't care about anyone but yourself. I mean, the names I've been called, right? Liar, gaslighter, cold and uncaring, of course. What else? Narcissistic, self-absorbed. It just, the list goes on and on. So we have this feeling of 1 minute we're being clung to, and the next minute we're being blasted with a machine gun. And so it's very confusing for the therapist. And it's also very confusing for the client.
And when that has happened for you, Janina, maybe in a very extreme case, what have you found helpful for sort of weathering the storm almost?
Well, I can tell you all the things I've learned that don't work. So what doesn't work is to try to have some kind of rational processing, right? So the client accuses me of being, a liar because I said X and then at another time I said Y. There's no value in trying to process that factually. It's much better if I say, oh, really? Wow. I can see how you thought that was lying. And now I'm just thinking maybe I've lost my mind because it does seem rather odd that I said this on last Tuesday and then I said this other thing this Tuesday. So, yes, I can see why it was confusing. So I'm not saying, yes, I agree, I'm a terrible therapist, but I'm also validating the client's perception. Or sometimes I say, wow, could you tell me exactly what I said and how I said it? Because I don't get that I sounded critical. I'm not understanding how I came off that way. So obviously it's verbal, it's relational, but it doesn't get me into this messy situation of either having to defend myself or apologize for something I don't think I've actually done.
Yeah, definitely. And you mentioned earlier that psychoeducation can sometimes be very helpful for lowering a client's maybe resistance or defenses to therapy. And I wanted to ask, have you found any other ways if a client is resistant to therapy or um, approaching a subject, have you found any other ways effective for lowering those defenses or lowering the resistance?
Well, the most important thing is, and this I learned from Peter Fonagy, whose writing is so complicated I can't read it, but hearing him speak as a speaker, he's very eloquent. He's a wonderful speaker. And I heard him talk about, I think just before the pandemic, at a conference in London. And he talked about how could we expect that these clients are going to believe us, right? They've just met us. They don't trust us yet. They don't trust anybody. And we say things thinking that the client will believe us. How silly are we to think that we will be believed? He says, the first thing you have to do with clients is to establish that you understand. And if you don't understand, find out how to understand the client. And I thought, that's so, so, so true. And part of communicating that understanding is often through psychoeducation. So the client says, I can't sleep. I've just been having a terrible problem with sleep. And I say, yes, many survivors of trauma have trouble sleeping. It's the most dangerous time of the day for children. And they feel understood. Right? Um, or I say to the client, oh, here's the good news. You're not going crazy, but you did get triggered. Right? That's why you had such a strong reaction.
Okay. That's sorry, we were going to say something else there.
So what I'm communicating is I understand that your behavior, reactions, feelings are not pathological, right? They're not to be dismissed. They're evidence that you were traumatized.
Hmm. And when we're talking about working specifically with disorganized attachment, are there any things that you would recommend clinicians do or don't do that can be helpful in therapy?
Yes. Yes. And the major thing is don't get too close and don't be too distant. Try to find a middle ground because if the client is pulling for closeness and I get very close, that's going to then trigger the defenses like, uh-oh, danger, I'm too close. Even if the client is saying, no, more closeness, more closeness, more closeness, right? I need to talk to you every day. I need to know you're still there. If we end up getting too close, and by too close, I mean talking, texting, or communicating on a daily basis, allowing sessions to go beyond the bounds of the time, promising them that we won't abandon them, which is, again, I don't know a single therapist who started out in practice saying, I'm going to abandon all these patients in 10 years, right? That's not what we do. But when we get caught in this kind of interaction where every week the client is saying, I know you're going to abandon me. I know you're going to abandon me. And we promise, no, I'm not going to abandon you. We put ourselves in a difficult position because we haven't created enough distance for the client to actually experience that they can tolerate a little distance. And lo and behold, even if we haven't spoken in 5 days, I'm the same person. We're getting on just as we always have. It's like children. It's like children when, we learn that we have to meet many of children's needs, but if we meet them all, there are going to be 10 more. Right? And that no will become a bigger, scarier word if we never say it. That children have to hear lots of yes, but they have to hear enough no that they can tolerate no and still feel that the parent is there with them.
That's really interesting and helpful, I suppose. I think this leads me into another question I wanted to ask was around, you know, if a therapist is in the unfortunate situation where they feel it is right to end the therapeutic relationship, um, can you tell us about the I think you use a metaphor of a winding road and stick figures, um, on how to this. Do you remember? Do you know what I'm talking about here, or could you tell us about this, please?
I do. So I have two ways of ending the therapy. One is the when we have to end the therapy because it's untenable. Luckily, that happens almost never. But if there are times, I mean, I've had colleagues who were trauma survivors themselves trying to treat clients with huge anger issues. And it's just too frightening for the therapist. You can't do good work as a therapist if you're scared of your client. That's right. So, so when we have to do what I call an ethical termination, which is another reason never to promise clients that we won't abandon them, um, then I I do it on the basis that therapists have an ethical obligation not to continue a therapy that has become ineffective. And it's certainly never an effective therapy if every session is devoted to the client yelling at us and telling us what a terrible excuse for a human being we are. That's not an effective therapy. And usually the client isn't making progress. If it's a termination, or I prefer to call it a graduation, that occurs because the client is ready to graduate, or because our time, in the service or clinic has come to an end. Then I do the windy road approach that you mentioned. So I draw on a piece of paper, I draw a winding road and a little stick figure, and I say, right, you began this journey to recovery, however long ago it was. Um, and along the way, people joined you, right? So I might make another stick figure. I say, oh, yeah, here's Alice, your first therapist. And she helped you to get quite a way along this path. And then you met Julie. And I draw a little stick figure to represent Julie, your second therapist. And you and she did a lot of work, and you learned a lot from Julie. And now here I am. I've joined your journey, and you and I are going to go along, have gone along another chunk of the way. And now it's time for someone else to take you the next leg. And so to try to help them um, not catastrophize every loss. I mean, if we think about our own experience of having had therapists or mentors or teachers, right? Each one left us with a lot of knowledge and insight that we could take into the next mentoring, helping relationship. And so it isn't just you have an attachment and then you lose it. Then you have another attachment and then you lose it, which is a very depressing approach. Right? And I used to work in a hospital setting where we had to terminate all our clients and take on a whole new bunch of clients at the beginning of the next year or the next term. And so every year, these poor clients were losing their old therapist and gaining a new one who was a stranger. and it would take them half the year to anticipate, to mourn in anticipation of the loss, and then it would take another half a year to get used to the new therapist, which would give them only half a year of actual therapy. So I was trying to get around that.
For sure, for sure. Okay. So we've only got a few minutes left, and there's loads of things I'd still love to ask you. But one I think that I think would be important to ask is for a young clinician listening to this that is, you know, whenever they see what you've done with your working life and the impact that you've had on the field, it's incredible. And the people that you've collaborated with, like Bessel van der Kolk and Pat Ogden and these different individuals, have you any sort of words of wisdom for the next generation of therapists coming through about how they can best serve their clients and also make a meaningful impact in the field? Anything that you'd like to pass on?
Well, I think I'm going to pass on secondhand wisdom from Bessel van der Kolk, who said, and I agreed with him, of course, the instant he said it. He's, he said to the young therapist, train in as many modalities as you can. Because, because most traumatized individuals need a number of different approaches. They can't necessarily be successful with one and only one approach. So, yes, get your training, and then keep on getting post, continuing professional development that trains you in other modalities as well.
And would it be right in assuming here that you would recommend probably going deep with one, and then once you've got that sort of foundation, then expand that into different approaches, or would you just say,
I think it depends on the individual therapist. Um, I don't think you have to have a favorite. I think you can take what's useful from each of them.
okay, I like that. Well, Janina, this has been our third conversation, and I've loved every minute speaking with you and learning from you. It's just always such a pleasure. So thank you so much for sharing some of your insights and knowledge and wisdom with us today. And where can people learn more about your work? And if you were to recommend a book of yours to get started, where would you direct them?
Well, I would direct people to my website. And my favorite book of all the books I've written is Healing the Fragmented Selves of Trauma Survivors. So, how could I not recommend my favorite?
Okay. Thank you,
Okay,
Janina.
well, it's been a pleasure.